Thank you. I'm going to use this time to talk about what is emerging as my favorite part of the diabetes spectrum, and that's mitochondria. It's very interesting. All these years, we never got to the heart of the problem. So let's talk about the bio. And I'm going to talk a lot about the heart, and I'll talk a little about Imeglimin. Think about the bioenergetics of the heart, right? I don't know how many of you remember Arthur Guyton. Life is ATP to ADP and back. Nothing more. Nothing more. ATP to ADP and back. And there some heat is released, right? So in the heart, 65 kilograms of ATP is produced and consumed every day. 8% of the body's ATP consumption, highest mitochondrial content of any tissue. So I'm going to use this tissue to help us understand what's happening with the mitochondria. The pancreatic beta cell is the second highest with the amount of mitochondrial consumption that is there. So what is happening in the heart is this. So the mitochondria has an inner membrane and an outer membrane. Between the inner and the outer membrane, there is what is called the respiratory chain. The fuel through the tricyclic acid cycle, the Krebs cycle, reaches these points. This is the So reaches these 1, 2, 3, these are the points on the respiratory chain, and then there is a transfer of hydrogen ion. At some point of time, there is a leak of the hydrogen ion back into the membrane, that is called the proton leak, and that triggers the conversion of ATP to ADP, and that is how energy is produced. This is happening in all of us, and the important thing is that this is dependent on the fuel that we supply. If there is plenty of this fuel, you have a problem. You have paucity of this fuel, you have a problem. If your fuel is not partitioned, we have two separate sets of fuel, glucose and fatty acids. Fatty acids and amino acids are reserve fuels. Glucose is the preferred fuel, except in the heart. In the heart, fatty acids are the preferred fuel, right? So what happens in the heart? So this is exactly what happens, and the protein and the energy that is generated is what causes sarcolemmal contraction and myocardial function. Now what happens is, there is a partitioning of fuel. When glucose is present, it's plenty. Therefore, it's like the body gets ready for reproduction. When glucose is not present and fatty acids are present, the mitochondria become more conservative. What they do is they undergo mitophagy, they undergo autophagy, become more efficient. In fact, why do animals that undergo caloric restriction live longer? Because the mitochondria become more efficient. That all the ones that you don't need are recycled, correct? But what happens when the fuels mix? When you have caloric excess, when glucose is available all the time, you're eating throughout the day, there is both of these are available to the heart or to the mitochondria all the time. Now what is the beauty of this whole thing is that glucose promotes its own metabolism, inhibits lipid metabolism. Lipids promote their own metabolism, inhibit glucose metabolism. But when both are present, there is dysfunction. And dysfunction in the heart causes worsening of heart failure. In the kidney, causes Dr. Venkatraman's disease. In the skeletal muscle, exercise intolerance, which you talked about this morning. Therefore, ultimately, all the diseases that we are talking about is a problem with the mitochondrial chain, the respiratory chain. So, the current paradigm is that we treat the outcome, the beta blockers, the ACE inhibitors, the hydralazine, the nitrates, the evadraprin. But at some point of time, you really want to be treating the decreased mitochondrial capacity, the increase in the ROS, and the calcium and other sensing. So again, remember, this is the electron train transport. The first fuel is NADH to NAD. Electron goes to FADH. Then this is the rate limiting enzyme, which is cytochrome C. And then here is where the protein leak takes place, and you get ADP to ATP. Because of this, the pancreatic beta cell produces insulin, the heart contracts, the brain functions. All of this is because of this, right? Now, so there are two substrates, as I said. One is glucose, the other is fatty acids. And depending on what is present, there's a greater amount of leak. I talked to you about this partitioning. If you're any animal, when you're born, or any plant, there is a 12-hour partition. When food is available and light is available, when food is not available and rest is available. This separation of fuel is called fuel partition. And that is what works. So the basic function we have never looked at about mitochondria. So in the last decade, we've now had drugs that seem to work at the level of mitochondria. Unfortunately, not many of them are advanced. We have very little data on some of them. We have few CVOTs and RCTs, which will never happen. The first of these drugs is a drug called Imeglimin. It's been present for the last 10 years, approved in Korea and Japan, no FDA approval, has a DCGI approval in India, costs anywhere between 7 and 20 rupees per day. And how does it work? It's very interesting, this is metformin. Put a cap of CH3NH, NH3 on metformin, you get Imeglimin. Very simple. Remember, metformin works in the mitochondria. We have never understood it, but it works in the mitochondria. So how does it work? It works at 3 levels. It reduces reactive oxidation species. It moves the blockage that occurs in the C1 level of the respiratory chain, increases the amount of substrate that is available at the C3 level. So pretty much what it does is it does what caloric restriction does. It improves the efficiency of fuels reaching the mitochondria. This is what we need to know. This is the DCGI data that we have. This is the approval data. 1000 milligrams BID. Don't start 500 BID. The approved dose is 1000 BID. Initially they did a 500 approval, but now it's 1000 BID. Half-life is 13 hours. It's not metabolized. Eliminated unchanged in the urine. In the last 10 years, I've reviewed the pharmacology. I haven't seen any significant drug interaction. Renal impairment can be used between 15 and 45 at 500 BID, at 1000 BID at greater than 45. No dose adjustment in the hepatic impairment. No studies in severe renal impairment, that is dialysis and eGFR less than 15. 2 important side effects, nasopharyngitis, remember again DPP-4 inhibitors. GI symptoms are very low, especially, at least in my practice, I've used it in patients who don't tolerate metformin, so a switch works. How does it work? First, instead of shuttling it in the respiratory chain level 1, it moves it and increases the amount of uptake in level 3. Therefore, it increases the efficiency of the respiratory chain. Second, it improves the substrate for NAD to NADH conversion. This is NADPTMP, an enzyme that is necessary that actually improves the conversion of NAD NADH. Third, it partially inhibits chain 1. And this is where it is different from metformin. Metformin actually irreversibly inhibits chain 1. And that is why you never want to give metformin in mitochondrial diabetes. Because it irreversibly inhibits chain 1. Metformin is contraindicated in mitochondrial diabetes. We have no data on Imeglimin, but I would not give Imeglimin to anyone who has mitochondrial diabetes. How else does it work? There is this particular protein called the permeability transition pore. What happens is when there is toxic stuff that is accumulated in the mitochondria, this permeability transition pore is opened. When it's opened, these become systemic, the cell dies. It prevents cell death. To summarize, so this occurs in the beta cell. It also occurs in the muscle, in insulin resistance. Therefore, when it occurs in all these places, there's an increase in insulin production. It's a reduction in insulin sensitivity. That is why this drug seems to work at both the insulin sensitivity and the insulin resistance level. Heart, there is some data on the heart, mostly murine. We will not get a CVOT. This drug has no father, mother, multinational. There will be no CVOT. But it seems to improve HFpEF in a mice model, right? And improves acetylcholine-induced septal relaxation. Seems to improve glomerular injury, again in murine models. Seems to improve tubal injury and reduce interstitial fibrosis. Do we have data on CKD prevention of progression? The answer is no. Probably we need to generate it. The TIMES trial are about 1,400 patients. Probably we have more patients in India now on this drug. A1C reductions anywhere, just like any other modest drug, 0.5 to 0.9. Works a little better on top of a DPP-4 inhibitor, a higher A1C reduction. That is pretty much all. It can be used in combination. can be used in addition to insulin and seems to reduce the insulin dosage and the others. Right? A1C reduces, but when the A1C is around 8, comes down to by 0.8 to 0.9. About 40% achieve A1C of less than 7, which is something that is expected with any OHA. And pretty much that is it. I don't want to waste your time. This is the one Indian study showing the same data as the other European Asian study. So potential positioning, use it in patients where there is a risk benefit ratio, use it in the elderly, not an issue. In renal insufficiency, when other drugs are not tolerated, when hypoglycemia is not desired, each of these are a good way to use it. Again, dose is 1000 twice a day, diabetes, no data on pregnancy, lactation, preconception, childhood, surgery, alcohol intake. Do not use it in EGFR less than 15, reduce the dose of the EGFR is less than 45. So, this is what this is my favorite slide in the whole world. Yesterday is history, tomorrow is a mystery. Today is a gift. That's why it's called present. Thank you so much.